Welcome back to another episode of the CSE's podcast, this one being a part of the Summit on Responsible Investment. And I'm thrilled today to be joined by not one, but two guests to discuss two businesses, really, Treatment.com AI Inc. and Rocket Doctor. And with us today, we have Dr. Essam Hamza, the CEO of Treatment.com AI Inc., and Dr. Bill Cherniak, the CEO of Rocket Doctor. Just to start the conversation, Essam, I just want you to first introduce yourself and the company that you run, which is Treatment. Treatment is a public company, and just recently, you guys entered into a deal to acquire Rocket Doctor. But first, let's talk about Treatment, just the broad vision of that, and then we'll throw it to Bill to talk about Rocket Doctor.
Yeah, no, absolutely. And thanks for having us again. This is pretty exciting. It's something we're passionate about. Treatment started as a health tech company. The idea was to create a situation where it can be a tool for doctors to create an AI onboarding system, triaging system, to do a lot of the administrative work that doctors hate to do right now. The reason they're getting burnt out and run down and retire early is they don't want to be typing and looking at a computer screen. They want to be talking to the patients, and they want the patients who are in the clinic or in the hospital to be there for a reason, for the right reason, not for something that they could have been dealt with at home and so on. So it was an exciting thing. We'll talk a little bit more about Treatment in a second, but the reason I got excited about it, I'm a family doctor over 25 years. I've been in healthcare and health tech and the public sector probably for even longer than that. And the first company I took public was called CloudMD, if you remember that, before COVID. And then obviously we got a lot of attention during COVID. We were able to kind of grow it very quickly from a small company under 10 million market cap and very little revenue to over 700 million at the peak of COVID, and about almost 200 million in revenues, and grew the company quite a bit. I left that company about 3.5 years ago, took a little bit of time off. And then one of the things I was really missing in CloudMD at the time was a company like Treatment. I came into it thinking that it was going to be more of an investment for myself. And then when I looked under the hood, I just got really excited about technology, and we'll kind of explain that a little bit more, in a bit. But it made me excited to the point where I joined as the CEO. And for the last 1.5 years now, I've been running as the CEO and started bringing the team and started getting to a point where now we're at the kind of commercial inflection point of the company that gets people excited and investors hopefully excited as well. The first acquisition we've made now is Rocket Doctor, and I'd love to introduce Dr. Cherniak here, who can kind of explain Rocket Doctor a little bit and himself and where he came from, and then we can talk about how Treatment and Rocket Doctor fit in together.
Awesome. Over to you, Bill.
Great. Thanks, Essam, and thanks. Nice being here. And yeah, my background's in emergency medicine, family practice, and global public health, and actually got started over a decade ago in the nonprofit space, working mostly overseas in East Africa with a group called Bridge to Health Medical and Dental. I started and got involved in a high tech and diagnostics through that, and then working as an emergency physician from the GTA originally, and seeing folks coming into the hospital with really outpatient primary care issues that didn't need an acute care center. Was thinking, if we could combine these diagnostics and virtual care, we could keep people out of the hospital that don't need to be there and improve efficiency in the system and overall access to care, particularly for rural, remote communities and people who may lack primary care. Having spent a bunch of time also in rural northern communities up in Ontario as well as in Alberta. And so went to med school at University of Calgary. So we kind of straddle both east and west sides of the country. So started Rocket Doctor tentatively, and then the pandemic hit in the spring of 2020 and really kind of dove in head first. And so our model, is quite different from really everything else that exists across the country, in that we don't look at ourselves as a virtual walk-in clinic or virtual urgent care. We have no corporate practice group of physicians. We're much more like Shopify for doctors, where we're helping physicians to build and scale our own independent practices, largely virtually, but in some hybridized in-person and virtual models of care that really plug into the public health infrastructure. Then we take all those doctors, put them onto a marketplace, and direct them out to patients, again, in those rural and remote communities. And we're also in the United States. I did my public health degree at Johns Hopkins, did a cancer control fellowship at the NIH, worked with Kaiser Permanente for a bit, taught in LA for a little while at USC. And so, we focus in California, New York, and are largely tackling the closest thing to Canadian health insurance in America, which is Medicaid. And so we're off to the races there. And, throughout the whole 5 years of the company, we've raised capital over the years and built a proprietary HIPAA compliant technology platform, electronic health record. And our goal the entire time was to incorporate different AI tools, predictive analytics, in order to get rid of all that non-clinical administrative duties doctors are forced to be doing. So that's, similarly why this made good sense to team up with treatment and the team.
Yeah, and you guys mentioned a lot of great jumping off points here, but let's hone in on AI for a second. So you said during COVID, a lot of these ideas came to market, first in the form of CloudMD, now with treatment and Rocket Doctor. I guess it's pretty acute. What the issue was that because clients couldn't get into a doctor's office and get basic face-to-face with the doctor. So it kind of precipitated, much the reason that we're recording today. We all learned how to use cameras and talk to each other over the computer. But my point is, that really drove. But how have you seen adoption then of these platforms continue to grow in the world where you can walk into a physician's office? And how do you get that client to know when to use this platform and not to go into a physician's office, or in your case, Bill, travel very far to go to a doctor's office? How are you trying to train the clientele to do this so that you can both get more customers, but also, I think, support your vision of making a more efficient medical system?
Yeah, maybe I'll start. The old way of thinking of anybody can go anytime, anywhere, for any reason, is not sustainable, right? It's inefficient. I'll give always an example of, it's a Sunday night and you are a parent and you have young kids, and you're worried about your kid or yourself, and first thing you do is go to Google and you start typing in the symptoms, and you start getting freaked out by potential weird things that some blog is talking about. And so your options are, on a Sunday night, emergency room, or stay up all night freaking out until you can talk to somebody, hopefully the next day. And the new way of managing this is that, number one, you should have 24/7 access to something or someone that you can talk to help with triaging and onboarding. And our AI tools at treatment, we have that. We have the ability for an AI nurse to talk to you, 24/7, take the history and ask you the questions in a very, almost basically like a doctor does. It has kind of an AI brain, like a doctor's brain, in terms of figuring out which questions to ask and so on. And by doing that, not only in the background is it creating a history to give all that stuff to the practitioner, the nurse, or the doctor, or whatever, but it has the ability to triage as well, meaning that it can pick up if this could be something like a stroke or a heart attack or something serious that you should be going to emergency right away. But it also has the ability to triage to see if it needs to be seen in person. Do we need to touch the belly or look in your throat or look in your ear? Or can it be done through telehealth? Or maybe you need to talk to a nurse or a pharmacist and not a doctor. So the ability to triage is kind of really, really important. 24/7, on demand, at the point of care, triaging is the future of healthcare delivery around the world. It's not just here. And so what we want to get rid of are the waiting rooms that are full of people who maybe shouldn't be there because they just want a prescription refill, or they didn't really need to be seen in person to get the answers they need or whatever they needed, and have the doctors see the patients they need to see in person, and have all the admin work done ahead of time, so that the doctor's not typing and looking at a computer screen. They're able to handle a lot more patients. They're much more happy dealing with patients that should be there, and not worrying about patients that shouldn't have been there. And so the future is this kind of 24/7 AI triaging to make it so that the people in the clinic or the hospital have been invited to be there, and we know exactly why they're there for the most part. And that's kind of the future of the end goal around the world for healthcare. That's typically what it is. And in today's world, we can kind of talk about what Rocket Doctor is doing with some of the platform they have and the onboarding and the virtual triaging and the virtual emergency rooms and stuff. Bill.
To take it to sort of brass tacks, you think about it, back to your question, Joe, and you think about pre-pandemic, the Canadian Medical Association put out a report just in 2020, right before, that less than 1% of healthcare was done digitally. And in the United States, it was like less than 5%, which is still exponentially more than Canada, somewhere between 1 and 4. But Canada was close to 0. And then the provinces began funding it at the start of the pandemic. And then Canadians started becoming aware of this idea of virtual care. It's still a new concept. And many like I've seen thousands of patients myself on the platform clinically. And many people, when I'll meet with them, look, oh, this is so cool. I didn't even know this was possible. And, you think about online banking, when everybody would say, well, it's not safe. You can't do banking online. But now, when would you ever go into a bank in person if you didn't have to? The core is to what Essam was saying. You have to identify who is appropriate to do online virtual care versus who does require those in-person visits. And unfortunately, that's not been done particularly well to date. But those are key areas that we focus on, is knowing when it's right for virtual care and then matching to the right physician to have the best outcomes. And, I'll give you another example. Like I was working in the emergency department over the weekend. I still do a few shifts every so often. And literally, like I had, and this is in a sort of more urban center, and I had one patient who had an issue for 3 weeks, came in literally on a Sunday night. And I said, well, why are you here in the emergency department? What changed after 3 weeks? And they said, oh, well, I just thought it's still here. And you have a family doctor? Yes. Why didn't you contact the family doctor? Oh, I don't know. It's going to take me a month to get in to see them. Okay. Then there was another patient, 2 weeks. Why did you come in? I don't have a family doctor. Okay. And then there was another patient. Well, it was only 4 days, but why didn't you contact? Oh, well, I work during the week and they're never open when I'm available. And so it's like, okay, there's all these things that are outpatient in our system 5 years later is still struggling to get the message out to patients about when it's appropriate, how to do it, or to upgrade, primary care clinics and family doctors' offices to provide those supports. So often through, not trying to blame them because they have a lot of work to do and it's very busy. And so how do you use tech, take away the, administrative stuff, but then give after hours access and get patients informed on different supports they have that are available to them?
Yeah. And so you, again, raise a couple of really great points around democratizing healthcare. Like the idea of healthcare, to my understanding, is everyone should have access to it. And now that we have this technological layer in between it all, how do we ensure that no one gets left behind, right? Not everyone has smartphone, high-speed internet. So maybe from your perspective, guys, like what is your concept of democratizing healthcare? What is this mission? But also, what do we have to do to achieve that, to make sure that no one is left behind, that everyone has access to this new paradigm of healthcare?
Maybe I'm happy to start on this one. So, if you think about it, there's a couple of kind of key buckets. As you mentioned, one of them is just simply getting access to the ability to connect in a virtual ecosystem. And sometimes that might look like a phone call because you don't have broadband internet access. The federal government in Canada has been pushing policies to increase that. And we have different tools with satellite-based internet that's coming out that's improving access dramatically. So, that's kind of like a foundational level, make sure people have internet. We have partnerships with different pharmacies across the country because often there's a pharmacy in every really small town. And we've built these B2B device stations that we can put into the pharmacy. And then that has a tablet, you can get Wi-Fi. And so folks who don't have access can at least use those stations, as well as these Bluetooth diagnostic devices like digital otoscopes. So you pop the thing in your ear, doctor can be, in an urban center, patients in a rural community, you can see if they have an ear infection, these kinds of things that we're trying out. That's one bucket. And then just basically the idea of reimbursement to physicians to do the work virtually. So our partners south of the border, most of the major states have passed legislation that you have to pay virtual the same as in-person care. And there are different caveats that fund the sort of, office, clinical, bricks and mortar stuff separate. But for the doctor doing the clinical visit, the two should pay the same because the physician is providing a comprehensive medical visit to the patient. And BC, Alberta fully fund, and other provinces they don't. And so that's something also the Canadian Medical Association put out in a report last year, is encouraging the provinces to equally fund equitably, publicly funded virtual care, which is going to make it far more accessible for everyone also.
I would add one more thing. There's this thing about it, there's a shortage of doctors, right? And the way I see it is that there probably really isn't a true shortage of doctors. There's a true shortage of doctors in certain communities, absolutely. And there's probably a glut in other communities where there's too many doctors in one particular area that they want to live in. And so we're starting to see now the ability, and you're going to see this hopefully with Carney and others, where you're starting to remove the borders between provinces and the ability for doctors to, we're all educated in the same schools, we have all the same training and everything else. I think those barriers are going to eventually disappear, and a doctor in one community will be able to see, let's say in a city, patients anywhere in that province and hopefully across Canada, and give access to care to patients who are right now are without anything. I don't know, in Ontario how it is all the time, but in BC, literally every week we get a notice that there's an emergency room that's shut down or clinics that are shut down in communities, and their only option if they're sick is they have to commute 3, 4, 5 hours to the next hospital or the next clinic or whatever that might be able to see them. But they shouldn't have to do that. They should be able to access, initially anyways, virtually, some sort of care. And there shouldn't be any interprovincial, boundaries either as well. And I think we're moving towards that. And I think that's going to provide, between this and the AI tools that create efficiency, where you're having the 24/7 AI nurse available at any time for anybody, you're going to be able to, I think, see a lot of efficiencies. And there'll be, I also call the 3 Ps that are happy. So I think you're going to have the patient who's happy, but, having access and 24/7 care. And then you're going to have the provider, the doctor and the practitioner basically happy because they're not seeing patients they don't need to be seeing, and they can help a lot of people. Their practice is a lot bigger. And then the payer is going to be much happier as well, because these patients are not waiting 3 weeks until something is much more of a bigger issue and maybe needs surgery or it's already spread, and are seeing things in real time and dealt with in the community as an outpatient versus the very expensive emergency room or with surgeons or whatever else.
So I'll give you one more anecdote, which is I was covering an emergency department in rural Alberta last year in the summer, and a farmer came in. He had a strain to his leg 3 months earlier and was given a tensor bandage from the hospital. Went out, was doing his farming work, came back 3 months later, my leg still hurts. Had a look at his leg. He had not removed the tensor bandage a single time over 3 months.
Oh, wow.
His whole leg had fallen apart. Sorry to be a little graphic on this call, but it was a very unpleasant scene, and we had to take the thing down and send him to surgery and clean it all up. And this is something where it's like, if this guy just had an ability on the farm to connect with me virtually, I could have said, well, take the tensor bandage off. And it seems obvious, but it's like, it's not obvious to somebody that doesn't know. And the doctor has said, do this. And, and they don't have access because, they might live 2 hours away from the closest clinic, and it's busy, and they're working, sunrise to sunset. And so these are ways that these tools can be extremely helpful. And these kinds of things happen every day across the country.
Oh yeah. Preventable, disasters for sure. A couple more questions, but I do want to talk about the other side of this. And you did mention it, recruiting physicians that can treat patients on these platforms. You said there's no shortage, but there's obviously some barriers from the Canadian perspective, because interprovincially there's issues with obviously paying the doctors if it's one doctor in a province, but a client in another. I can see that causing some issues in today's construct. But that aside, he said there's no shortage of doctors. All I hear about is the fact that there is a shortage of doctors. So maybe just touch on how do you get more physicians onto your platform, and
I'll hand that to Bill in a second. But when I say there's in my mind, doctors don't like doing paperwork. So for every 5 minutes that I'm seeing you in a clinic, I'm probably doing 20 minutes of paperwork, right? If we can remove that, number one, and make it so that a lot of these AI tools that are listening to our conversation and able to transcribe the notes and everything else. But in particular, if I can have, let's say, our AI nurse available for every one of my patients before I even see them, and is taking the history, onboarding them, triaging them, we have the ability to send, blood work, the blood work they should be doing, and all that being automated before the visit, so that when you see you, number one, I know exactly why you're coming. It's an appropriate visit to be there. You might have already done the blood work, and everything else ahead of time. And I'm not being surprised by a potential heart attack that shouldn't have been waiting, or something like a prescription refill, or, something where they don't need to be there, particular. They had just a quick question, right? And they took a spot from somebody that could be seen. So my practice can now go from handling only 2,000 patients, because that's all I can without going crazy, to maybe 10,000 patients, because I literally have unlimited nursing, AI nursing kind of helping and so on. So everybody, the doctors will be able to, number one, be happier, They'll have the tools for them that support them and give them comfort and do all the admin work, even the billing part of it and all that part of it. There's even tools on helping look through the inboxes of the results that are coming in and things like that. The AI tools coming are pretty impressive. But, in particular, then if I'm going from a 2,000 person practice to 10,000, yeah, there isn't really that shortage. And I might see patients that are maybe 1,000 miles away, right? And so the scope of the community, that I have, that is much bigger than it was before. And Bill can talk a little bit more about how the doctors are coming onto the platform and very excited about this.
Yeah, well, I'll give just at a high level from a data perspective, we've done postal code analyses of the patients on the platform. And what we know is that consistently something like 40% of patients come from communities with populations of 25,000 people or less, about 20% from designated rural communities, which is 1,000 people or less. And in places like BC, over half the patients are from outside of metropolitan centers, so from small towns. And I always get reminded of a really interesting anecdote from Dr. Danielle Martin. She's the chair of family medicine at U of T, where I'm a faculty, and she testified at the US Senate years ago, Bernie Sanders and a bunch of other folks. And, one of the folks went after her for the Canadian death panels and whatever else was going on and how everybody's dying on waiting lists in Canada. And she said, what was interesting as I came into the Capitol building today, and the line at security, I waited like 20 minutes in line. And then I got into the building and I saw that there was no line at another security station. And that's a lot like the Canadian system, where you've got all these doctors concentrated in urban academic centers. You've got no doctors in these rural communities because, having worked there as an ER physician, flying in and flying out, you're living, it's a totally different way of life, and not everybody wants to do it. And for obvious reasons, they concentrate. So what we're doing at Rocket Doctor is we're taking all of these doctors that are in these urban centers, and now we're beaming them out to patients in those rural and remote communities where they often would not be able to access a doctor on a regular basis. And so that is how we're able to recruit more physicians, is that they don't have to go fly away and leave their families and leave their jobs and leave their apartments. And they can actually just open up their computers and then provide the same quality of care in a rural center. And I will say we're also in the United States, and in the US, the problem looks quite a bit different, which is actually Medicaid, where there's this kind of firewall of insurance between doctors and patients. And so there's an enormous volume of doctors that would like to provide care to patients in need on Medicaid, which is health insurance for folks at or below the poverty line, pregnant women, children. You may have heard a lot about it in the news lately, going on down south about what they're taught. But the states we're in California and New York are increasing access to care and trying to figure out how do you break down the barriers of taking insurance for those patients. And that's what we've figured out how to do in those states. And so we're recruiting doctors and building patient demand on that side of the border as well.
Yeah. And again, to your point, Essam, it's improving capacity, what's available. And then to your point, Bill, if we can break down the barriers of how these urban doctors can support the rural patients, obviously a clear use case. Just a couple more questions. I just want to, and I talked to you as well about this, Essam, before, but the concept of longitudinal care.
Yeah.
Just to make sure that people are aware that users on this platform or patients and clients are forming long-term relationships. Yeah. This isn't just come in, get something, diagnosed and then off you go. This is right. A long-term.
100%. And that's the point, is that medicine shouldn't be that bad. Medicine shouldn't be, I see you once and I don't want to think about you again kind of thing. It's about listening to your story, figuring out what's bothering you. I mean, not everybody has the ability to succinctly kind of say exactly what's wrong and everything else. So the ability to kind of listen and figure out what you're complaining about, but it takes time. It sometimes takes time. Maybe I have to send you for blood work, and maybe I have to send you for a referral to a specialist or whatever, but somebody has to be the quarterback here. Somebody has to be able to receive that back and be able to say, okay, now this, and it can't be the patient, because not everybody is able to do that or should be doing that, and things will fall through the cracks if that's what happens. It's you're asking the patient to monitor the results coming back and figure out if they have to follow up. The tensor bandage will happen, right? And so it's one of those things where you have to have that quarterback. Longitudinal care is the future, but you also don't want to put that burden on doctors to do a ton of administrative work, because that's when they get scared of taking on more patients. But if you're saying to them, no, all these AI tools, all these digital tools that are on the platform can do all that for you. So you can just see patients and and take care of them, and that's what you want to do, they're more than happy to do it. And that's why I think you're seeing this explosion of growth on the Rocket Doctor platform in certain provinces and so on, is that they have the ability to work whenever they want, wherever they want, and not be tied down. And then the tools are making it simpler and simpler for them to be using it as well. And it's only going to get better. Like I was saying, we have a demo right now that we're using an AI nurse talking to the patient from 3-4 months ago. And it's great, but there's a little bit of latency and things like that. And then I showed a new demo with a new technology 3 months later that is spectacular. Now it can pick up any language. So there's no language barrier. So literally the patient could be speaking any language. It's going to pick it up and start speaking back to them in that language. And, we're coming out with an avatar. So for some seniors or whoever, or in a pharmacy kiosk, you can actually see the doctor, an AI doctor with a stethoscope talking to you. So it's not just the voice, part of it. And so the technology is only getting better and better and better that way. And with our GLM, Global Library of Medicine, which is, like I said, the AI brain that powers all these things, we're able to present it in many, many different ways. So it's exciting, and stay tuned. Let's just say, yeah.
On the longitudinal care piece, the whole thing that's also unique about what we're trying to do, I agree with everything Essam said about how to improve the lives of physicians that are practicing in this way. The other thing is, most of the current solutions that exist are these kind of walk-ins and urgent cares, which, have their place and can in some cases be valuable. But the difference for what we're trying to do is, let's give you an example that, I see you, Joe, and you've got a sore shoulder from going to the gym, and I order an ultrasound and give you a course of anti-inflammatories and say, come back in 2 weeks to see me if you've got a rotator cuff tear from that ultrasound. And, we go away and I go on vacation for a week. But then in the meantime, you get a fever with a cough, cold, and you think, oh God, do I need the emergency department? What's going on? I feel terrible. You come onto the platform, the team will, and we have a team of care coordinators that helps to work with every patient to, fit them through. And so they'll say, hey, well, Dr. Cherniak's away for the next week on vacation. Would you like to wait for him, or would you like to book an appointment with the next available physician? Most people are going to say, book me the next available physician. And then that physician will have access on our cloud-based electronic health system to all of your past medical information, all of your history, all of your records. So they actually know all about you already. And with the treatment tools built in, it'll be able to summarize that for the doctor and other things. We connected through a shared contact at Google. We're doing a lot of work on large language models and summarizing data and that kind of stuff. And so we'll be able to give that to that urgent care doctor truly. But then you come back and see me where I ordered the test. Now it's 2 weeks later. I'm back from vacation. You've had your intermittent visit. I have all the records from that urgent care visit. It's again summarized for me. I have a clear handle on what's gone on. I can talk to you about what happened. We avoided that unnecessary trip to the emergency department in the middle of the night. And now you're still getting that ongoing longitudinal care. So what we're doing is creating capacity in the system so doctors don't burn out on an island as family physicians, and they're actually way more supported. It's something that's different and unique. And so the provinces don't fully understand that model just yet, but we're getting kind of the word out, and certainly patients appreciate it. Now over 600,000 visits across the country and growing.
Yeah, that's amazing. And again, I as myself a patient in the medical system, I appreciate what you guys are going for here. Okay, last question, and this one's a bit of a curveball. We talked about Dr. Google a little bit in this conversation. Now, do you compete with Dr. Google, or does Dr. Google work alongside you? And by that,
yeah,
I mean, you might not be the only one using AI and trying to build a better, more efficient medical treatment system, but is there something happening in big tech and with the Dr. Google that is a threat, or does this support what you guys are doing?
Yeah, no. So I'll kind of put it in 3 buckets. Dr. Google, or the search engines, are the old way actually. So that's already outdated. But at least it gives you links. So a Sunday night you're typing it in, you see the links, you can click on the links, you can see if the link is okay or not, or if it's some sort of blog. Not everybody is able to kind of distinguish between those two things, but still, at least you can see where the source is. The bigger threat to healthcare right now are the large language models, so ChatGPTs of the world, because what they do is they scrape the internet for good or bad. So again, garbage in, garbage out type of thing. And then they spit it out in terms of a response as if it's very accurate, which studies have shown that it's incredibly inaccurate. And they don't have the audit trail often of where it came from or how they came up with that decision of what you have. And then you have the hallucinations, and then you have, the racism that sometimes appears, and then the fact that one answer one day is completely different than the answer another day, and so on. The consistency is not there. And in healthcare, you can't have that. You can't have 60% accurate, right? I mean, you have to have close to 100% accurate, or it's not useful. So that's number one. And so what we have is something what we call curated AI. It was created by a couple hundred doctors around the world in an umbrella over about a 7 or 8 year period of time that curated this information, brought it into a panel of physicians and the science team to put into the global library of medicine that we have. It's protected. It can never be contaminated by any outside source. It'll never hallucinate or become racist or anything like that. And so it's protected knowledge base that's always updated at all times. But more important than that, you can always trust it. And when I say that, I'm saying that, the biggest stamp of approval right now is it's being used by medical schools in the US and soon to be other places to test and train and give instructions and remediate actual medical students in medical programs. So I'm telling you, as you're going through medical school, and Bill can say the same thing, they're very protective of their medical students and where they're getting their information. So the fact that they're trusting a company like us to not only test their students, but train them on what they're missing and how they are asking questions and the diagnosis they're coming out with is a big stamp of approval, right? And the accuracy rate is incredibly good. I talked about it being thrown into one of these medical exams that students have to go through to graduate, and we gave it to a non-medical student, and she got 11 out of the 12 right, and the 12th one on the second diagnosis, basically. So almost 100% accuracy, which is way better than any student going through that same thing. And she doesn't have any medical training. So the accuracy is there as well. It's trusted. It's really important. But you brought up a really good point. So it's not really a competition in that sense. What I see it as a collaboration. I mean, we are talking to obviously Google. That's how we met, and others, where all these large language models need a source of accurate information to draw from. So instead of it being scraping the internet indiscriminately, if it's actually scraping from or taking the information from the global library of medicine and then giving the answer, that's where we see kind of the future leading to.
My piece there would just be to add that we would never want to compete with Google or Amazon or any of the other Microsoft or any other chat GPTs of the world by building our own large language models. Like, though good luck. Like, they can run those LLMs and they'll continue getting better and better and more commoditized and cheaper. We just plug those LLMs into our software ecosystem. And then, as Essam said, we build prompts around it. We refine them. We build the user interface. And we have the most valuable thing, which is data, to train them to get that in an ethical, responsible way with clear privacy policies and in a way that benefits patients and isn't shared to rebuild the model itself, but is only used to improve patient care directly in our system that's private and otherwise compliant. So that's the way I would think about that.
Yeah. And again, I think your whole business case is sort of how I see the future of AI, which is it's supplemental, it's a tool. It helps the humans be better humans, right? We get to apply our experience, our intuition into these scenarios without having to be over reliant on the technology, but certainly having it as a backstop and also as a way to make our processes more efficient. I've observed my friends who are cranking away on the admin work for their patients, and it seems like, well, you're a doctor, like, go help treat.
Yeah.
So that seems like what their role in the world is. This has been fascinating. I love this topic, and I certainly appreciate what you guys are doing. And I really appreciate you coming on the show. Just again, for those watching, if they want more information about both treatment and Rocket Doctor, where should we direct viewers?
Just our website, so treatment.com. You'll be able to see everything about treatment, and you can watch the videos and see kind of the different opportunities. Rocket Doctor has their own website as well, but you can, I think, go through treatment as well and access it. But if you're living in Canada, in certain provinces, and you want to use the services, maybe, Bill, you can kind of explain the website for Rocket Doctor in Canada.
Yeah, well, for physicians, you just come to our website and become a Rocket Doctor, basically, and get started. So we're always looking for docs in all the provinces, but especially BC, Alberta, Ontario, Atlantic Canada now as well. So feel free to reach out to join us there. From the patient perspective, similarly, rocketdoctor.ca, and you can just follow. It's quite easy. You follow to your province that you're in, and it will guide you through the various submission processes. So it's all quite straightforward. So yeah, I would just tell folks to check us out on the website. and we'll guide you to the right place.
Awesome. Well, once again, this is a company, Treatment.com AI Inc. It's listed on the Canadian Securities Exchange under the symbol TRUE. Gentlemen, thank you so much for joining us today. And this was a special presentation of the CSE podcast in line with our Summit on Responsible Investment coming up on June 5th. And if you're watching this video after the fact, simply go down and look at the playlist that this is a part of. Lots of great topics discussed during the summit this year. So once again, gentlemen, good luck. And thanks so much for taking the time today.
Thanks a lot. Thank you.
Thanks. Appreciate it.